The Mary Pack Arthritis Program provides a multidisciplinary team approach to assessing and treating both inflammatory and degenerative arthritis conditions. In occupational therapy, we prescribe supportive shoes and functional foot orthoses to our patients to reduce their foot pain and to improve their function in standing and walking. To assess a foot with rheumatoid arthritis, we start by asking our patients about their pain. Where is it? When do they experience pain? What makes it better or worse? We then assess each joint for active inflammation and note which joints have been damaged or deformed by arthritis. Next, we look at the underlying biomechanical structure of the foot. And lastly, we assess our patients in weight bearing, both standing and walking, to understand how all the factors listed above affect their function. For the purposes of this video, we will focus on two important components of the RA foot assessment. First, we will assess each joint to determine if inflammation is present. Then we will assess the underlying biomechanical structure of the foot to determine if there is a pre-existing abnormality that can contribute to foot dysfunction. We assess joint inflammation using a rheumatology test called the joint count assessment. At each joint, we look for swelling, pain with pressure called tenderness, and stress pain produced by overpressure at the end of joint range. These three tests are done in the same order, and once you get a positive response, you do not need to perform the subsequent tests. If a joint has severe deformity or is fused or has been replaced, these tests are not valid. Today we will assess the ankle, the subtalar joint, the mid-tarsals, the metatarsal phalangeal joints, and the interphalangeal joints. We will look for swelling, tenderness, and stress pain, which indicate the presence of active inflammation. To test for swelling at the ankle, first ensure that the ankle is in slight plantar flexion, and then position your thumbs on the anterior aspect of the joint on both sides of tibialis anterior. Palpate for swelling by applying pressure, alternatively under one thumb and then under the other. Try to detect a fluid wave-like motion. If swelling is detected, the test is positive, so proceed to the next joint. If it is negative, test for tenderness. Again, with the ankle in slight plantar flexion and your thumbs in the same position, apply pressure under both thumbs at the same time. The pressure should be strong enough to blanch your thumbnails. Ask your patient if the joint feels tender. If positive, proceed to the next joint. If negative, go on to the test for stress pain. Here, ensure that the knee is flexed and then apply overpressure to the ankle at the end of the available range in dorsiflexion and ask if this is painful. Next, we will test the subtalar joint. Due to the structure of this joint, there are no reliable tests for swelling or tenderness, so we test for stress pain only. With the ankle at 90 degrees, stabilize the lower leg with one hand and grasp the calcaneus with the other. Invert the hind foot fully and apply overpressure at the end of available range. Ask the patient if this is painful. If it is not, repeat the test in eversion. The mid-tarsal joints are assessed as a single group, using only the stress pain test. With the ankle in dorsiflexion, stabilize the calcaneus with one hand and place the other hand over the shafts of the metatarsals. Apply overpressure at the end of inversion range. If this is negative, test in eversion. Be careful here not to apply pressure to the metatarsal phalangeal joints. They may be inflamed, so pressure there could lead to a false positive. At the metatarsal phalangeal joints, we combine the tenderness test with the test for stress pain. With the joint in slight plantar flexion, position your index finger and thumb anterior and posteriorly on the joint line, just distal to the metatarsal heads. First apply pressure, then apply traction, and lastly, apply overpressure to the limit of their plantar flexion range. The remaining 4 metatarsal phalangeal joints are tested the same way, and any painful areas are noted. The interphalangeal joint of the first toe and the PIP and DIP joints of the lesser toes are assessed using the tenderness test. Apply pressure over the anterior and posterior surface of the whole toe and ask the patient if it feels tender. This completes the joint count assessment of the foot. It is a reliable, valid way to determine the presence of inflammation due to rheumatoid arthritis. Next, we will look at the biomechanics of the foot to see if there's an underlying structural malalignment that might contribute to foot dysfunction, especially in the presence of inflammation and joint damage. We assess the foot in non-weight bearing with the patient lying prone and their feet hanging over the edge of the plinth by approximately 6 inches. First, we assess the relationship between the lower leg and the hind foot. In non-weight bearing, is the hind foot in neutral relative to the leg, or is it in a varus position, meaning toward the midline, or in a valgus position, meaning away from the midline? Next, we want to assess the relationship between the forefoot and the hind foot, and we use the same terms to describe its position. Once the patient is comfortable on the plinth, ask them to relax their foot and then position it so that the plane of the back of the calcaneus is parallel to the floor. To help position the leg in neutral, ask the patient to roll slightly onto their hip or position their opposite leg with the knee flexed. Next, the subtalar joint is positioned in neutral. On a left foot, the right hand palpates the subtalar joint with the index finger and thumb placed on either side of the head of the talus, located below and forward of the malleoli. The left hand holds the 4th and 5th toes. The subtalar joint is then moved through a full range of inversion and eversion as pressure is felt alternately on the index finger and the thumb of the right hand. This arc of movement is gradually diminished until pressure is felt equally on the index finger and the thumb. In this position, the left hand distracts the foot towards the floor and dorsiflexes it until resistance is felt. This mimics the foot at the mid-stance phase of the gait cycle. With the foot held in subtalar neutral, we can now observe the position of the hind foot and look down the plantar surface to see the position of the forefoot. Is a line bisecting the calcaneus in a straight line with one bisecting the lower leg, or does the hind foot sit at a varus or a valgus angle? Next, we imagine a line at the level of the metatarsal heads. Is the forefoot in a neutral position perpendicular to the hind foot, or is it in varus or valgus? Here we can see that the hind foot is in neutral, but the forefoot sits at a varus angle relative to the hind foot. Let's take a closer look at the 3 most common biomechanical alignments. Most people have neutral biomechanics. Here, the hind foot is in line with or parallel to the lower leg, and the forefoot is perpendicular to the hind foot. In standing, and in the absence of other foot pathology, a neutral foot would have a well-formed average height arch and a hind foot in neutral. It is well adapted for standing and walking. Like our patient, here the forefoot is at an angle. The line at the level of the metatarsal heads is not perpendicular to the hind foot. Instead, the medial border is higher than the lateral border. This is called a forefoot varus. In standing, this foot has a low arch and a hind foot that sits in valgus. This is a pes planus, or a flat foot, and causes our patient to have excessive pronation during gait and poor propulsion. In this example, we see a forefoot where the medial border is lower than the lateral side. It creates a valgus angle relative to the hind foot. In standing, this foot has a higher than normal arch, and the hind foot sits in a varus position. It is a pes cavus foot, which causes the patient to have excessive supination during gait and poor shock absorption. These tests for joint inflammation and biomechanical anomalies are important components of a complete foot assessment. They add to our understanding of our patient's foot problems and help guide our prescription of appropriate interventions. People with arthritis who have foot pain, active inflammation, joint damage, and biomechanical problems can benefit from conservative treatment. The provision of properly fitting, supportive shoes and custom foot orthotics have been shown to be effective in reducing pain and improving standing and walking ability in people with rheumatoid arthritis.